Good morning. Do not adjust your set. I am not Dr. Steve Stites. I'm Dr. Sean Coomer. I'm a transplant surgeon and Associate Chief Medical Officer here at the University of Kansas Health System. Dr. Stites is taking some well-deserved time off, and we will definitely be filling in for him and singing his praises. Today, we're talking about a surgical solution to migraine. Roughly 1 in 10 people live with migraine. Those people can tell you migraine attacks are way worse than just a really bad headache. The pain can last for hours. It can make you throw up and feel nauseated. And once the migraine attack wears off, some people feel exhausted for a full day or more. Here's how one patient described it.
I've been on a journey for the last several years of trying different medicines, working with the doctors to try and reduce the number of migraines that I have every month. I've had headaches my entire life, but they've been worse ever since I went through cancer treatment 6 or 7 years ago. And the migraines they're pretty debilitating.
That story is common among the millions of migraine sufferers, but that patient found relief thanks to a new kind of surgery. Here's how her surgeon describes it.
So for her, what we'll do is we will make an incision kind of in her upper eyelid, very much like doing an upper eyelid lift or tuck kind of procedure, very much like doing a carpal tunnel release in somebody's wrist, where we take pressure off the nerve in the wrist and help with sensation in the hand and the fingers. Similarly here, we're taking pressure off of those nerves in the forehead.
He makes it sound so simple. I'm sitting next to that patient and that surgeon today. Sarah Lamb had migraine relief surgery about 5 months ago. Welcome.
Thank you.
Dr. David McGee was her surgeon. He's a plastic surgeon and a hand surgeon specialist here at the health system. In a few minutes, we're going to hear and find out why a hand surgeon is actually working on someone's forehead. Sarah, can you tell us a little bit about your history of migraine and how long you've lived with it?
Yeah. I unfortunately have lived with severe headaches and migraine almost my entire life. As a child, we used Dimetap, Sudafed, and over-the-counter medicine to try and fix it all the way through high school. And then as I got older into my 20s, they just got worse. Everything, we always thought they were sinus headaches is the term that we used for it. But I got educated and learned that they were migraines. And then they've consistently just gotten worse over the last 10 years, like we said in the soundbite, after cancer treatments.
Yeah, so it accelerated after cancer treatment.
It did, yes.
In what way?
The intensity was greater, the frequency was greater, and there wasn't really an obvious reason why. There's still no real correlation to what may have happened to my body as a result of that, but I just found myself, in bed on the couch, unable to do things more and more days of the month.
So how you mentioned the frequency and the intensity, but how often would you have these headaches? Migraines, excuse me.
Yeah.
Made a difference.
I track them in my health app so that when I go to the doctor, I'm able to give an idea of how many. And it was upwards of 15 a month, sometimes between 15 and 20 days that I would track a migraine.
Wow. No. So is it? So what are the symptoms? Can you describe that to folks?
Yeah, for me, they always started in between my eyes. I do get Botox for migraines now, and one of the great benefits is that it got rid of this furrow that I had right here from kind of being like this in pain often. But the pain would just basically start there, kind of a deep pressure, a little bit of throbbing, and then would just build and spread, kind of across my head. Every once in a while, I remember a really bad one within the first year of COVID, because I was thankfully working from home and just didn't get out of bed because it was radiating over my ear. The entire side of my head was just in massive pain, and all you can do is take all the things you have and use heat or cold or any other over-the-counter or random internet devices to try and feel better.
Yeah, that sounds horrible. But when you describe what's a bad day and what's the day after the bad day like, after you have the migraine?
It's the bad day is really just that. It's just feeling really crummy. It's just either being, either slightly crummy and just kind of stuck being inactive and doing nothing, or being completely debilitated and just going back to bed, likely being unable to sleep because it hurts. And then typical cycle for me is by the end of the day, once the medicines have all done their job, the headache's gone away, I'm wide awake and I can't sleep. So then the next day I'm dragging and tired, and then very likely the day after that I would get another headache. So
Yeah. Oh, yeah.
it's just a cycle.
But surgery is not really the first treatment option. What kind of medications do you use and did you try over time?
Oh, yeah, you know, I tried all the things, not just because insurance makes you try everything before they'll give you the latest and greatest, but started off taking sumatriptan was my first prescription treatment pill. Also was on Topamax for a few years, which is more of a daily preventative, but it's also has a bunch of side effects that come with it. The pharmacist told me that their nickname for it is Stupamax, because it does make it very hard for you to find words. And being on it after having suffered from chemo brain, I wasn't really enjoying the inability to find words and to stumble. So, you know, moved on from that. I never really wanted to take a daily preventative, and Dr. Ford, my neurologist, was really great in understanding, trying to find that balance for me. I've done Nurtec, I've done Ubrelvy as one of my current ones. We've changed up my triptans to just try for whatever's most effective. And then most recently I started taking Qulipta as a daily preventative. And there were a few other things in between that I had to try, like blood pressure medicine and a few other things that just didn't, antidepressant. Like there are drugs that, you know, have that secondary benefit use that you just have to play the game, do the dance.
Yeah, I mean, you're certainly well educated and been down a long road, obviously. And what was the tipping point that led you to seek out surgery?
So my neurologist had mentioned it as an option to me a while ago, and I did forget to include Botox in that list. That is technically a medicine. And it had always been in the back of my mind. It's like, all right, we're just going to keep exploring other things, keep trying medication treatment options. There was a weekend about a year and a half ago where I had gone to my hometown, Wichita, Kansas, which is only 2.5, 3 hour drive away, and gone to an outdoor concert with some friends, and there were people in front of me who were smoking cigarettes throughout the entire concert. And anytime my sinuses are really impacted, that's definitely a trigger for me, and so smoke was a big factor. So the next morning I woke up and was like, all right, I'm just gonna go get on the road, get home, you know, took medicine anticipating I was gonna have a headache, ate pizza for breakfast because certain foods do help prevent headaches. But I made it about 20 miles before I had to pull over and vomit. I was nauseated, and what should typically be, like I said, a 2.5 hour drive, like I made it 3 hours, and I was still only to Ottawa, Kansas, which is still an hour away. I had to call my husband and say, can you please have my sister drive you to me so that you can finish this drive home? Because I just had to stop every 15 to 20 minutes to throw up. I couldn't keep my medicine down. It's also really tricky to take something that is an anti-nausea while you're operating a heavy machinery, a heavy vehicle, operating heavy machinery at a fast speed.
Right, exactly.
That's not safe either. So yeah, it was such an arduous trip. And it was just kind of the final straw where it's like, I should be able to do something as basic as going to a concert, going to do something.
Yeah. It obviously tremendously affected your life.
It did, yeah. And it's a little frightening. Like once it gets to that point of, you know, I can't do the things I need to do to live, like drive a car. That's not okay. So.
Yeah. Well, Dr. McGee, you're a hand surgeon specialized after plastic surgery training. How does a hand surgeon wind up doing this kind of surgery?
So that's a common question that I get. I have patients who show up in my office on a routine basis asking why they're seeing a hand surgeon when they're having headache pain or when they're having all sorts of nerve pain all over their body. Because my kind of special interest in practice is nerve problems. And so in this case, what we're dealing with is a patient who has a peripheral nerve that's irritated that then seems to create a sensitization pathway that creates a headache. And so in this case then, I'm operating on a nerve like I do on any other part of the body, and as a plastic surgeon, operating on the face is a very, very common part of what I do.
Yeah, obviously you did a lot of training for that, that's for sure.
For sure.
So how new is this procedure, and how often do you perform this?
So headache surgery like this has been around for about 15 years or so. Kind of started by a guy by the name of Bauman Guyron in Cleveland. He kind of came across the idea serendipitously when he was doing a lot of cosmetic surgery on patients, and they told him that they were so happy that their foreheads looked better, but also that all of a sudden their headaches were a lot better. And so from that experience, he learned and he started developing these things. Here in Kansas City, we are doing it fairly routinely, 1 or 2 a month. But we also recognize that there are a lot more patients out there who are having difficulty getting access because they don't know about it. And I actually see a fair number of patients now who were previously set up to go out of town because they discovered this online somewhere else and were set up to go to St. Louis or Nebraska or Denver, and then they found out that there was someone here in town and they wanted to stay home.
Right. Now, clearly this is a procedure that is not to treat headaches, it's to treat migraines. And you can't treat every person with a migraine. What
Correct.
made Sarah a good candidate for this?
So the first thing is a patient needs to be under the care of a neurologist. They need to have been evaluated to make sure there aren't any other reasons for them to be having headache, pain, migraines, or things like that. Because I'm not a migraine specialist. I'm not a headache specialist. I'm a plastic surgeon who does procedures that improve these things. After that, if they've benefited from Botox in particular, that is a good predictor of success for surgery because Botox, the most potent poison known to man right now. We paralyze the muscles that are irritating some peripheral nerves that are already kind of grumpy. And if we demonstrate that those nerves, after we've kind of quieted down the muscle that's irritating them, do better, then the expectation is that by decompressing that nerve, by taking pressure off that nerve, we can decrease the frequency and the intensity of the headaches the patient's experiencing.
That's fascinating, and I can see why it works. We've got some video from Sarah's surgery, and before we show this, we want to consider this a warning to anyone that's squeamish. There's not a lot of blood or anything like that, but if you don't want to see a surgery, please look away now for a few minutes. Dr. McGee, if you could describe some of the things you're doing here, you're working on the eyebrow area. What are you doing here?
So, getting ready for surgery, putting in corneal shields to make sure we don't scratch her eyeball, because that wouldn't be a great way to start out the day for her. Putting in some local anesthetic with some epinephrine to keep things from bleeding, because I don't like having people bleed all over while I'm doing that. And now we're doing essentially an upper eyelid incision like you do for blepharoplasty. We're getting underneath the orbicularis muscle, and we're going to go down and find the supraorbital nerve and the supratrochlear nerve above her eye, and release some tight constricting bands in the corrugator muscles. And then also, in her case, we had to open up a little bone tunnel a little bit in addition.
Okay, I guess that's what you're referring to as a moment when you use a tiny mallet, and is that what you're talking about?
Yeah, we're using a little osteotome, just kind of opening up the bone there a little bit more, where she had what's called kind of a tight foramen. In this case, the nerve coming through a tight bone tunnel, and have just opened that up and give it a little more space to breathe, essentially.
So you're creating more room so that where the nerve comes out through the bone,
Exactly.
and that doesn't irritate and inflame as much.
Exactly. Take traction off the nerve and then also decompress it.
Now, obviously, you went started one side, and then you moved to the other side.
Correct.
Okay. All right. So how long does this surgery take?
So for the surgery that we did for Sarah, about 90 minutes or so.
Okay. And that includes the anesthesia and the whole rigmarole before and after, or is that the actual procedure?
That's probably wheels in to wheels out.
Okay.
Don't put a stopwatch on me for that, but I think that's the ballpark.
So how soon after the surgery, can a patient expect relief?
There are a couple things that we think about in preparation for that. The first thing is that some patients can have almost some rebound headaches right after surgery, just because we've gone and monkeyed with those nerves that are already kind of grumpy and can sensitize patients. So sometimes we counsel patients in advance, or always we counsel patients in advance, that they could have some worse headaches at first. Although we expect that pretty soon after surgery, within a few days, patients should be able to notice a difference as far as kind of almost the resting discomfort that a lot of migraine patients will tell you. They always feel something there, and it's a question of, is it going active and turning into a migraine, or is it just kind of sitting there, hopefully kind of dormant? And patients can usually tell us early on if that has improved or not.
Okay. Sarah, you shared some photos of your recovery. How long did it take you to feel back to normal? And did you have any of these rebound headaches like Dr. McGee was referring to?
Yeah, I really did not have much of the rebound headaches, thankfully. And I think I felt fully normal within a couple weeks. You know, it was, I had my check-ins with Dr. McGee, and it was always just like, I'm doing fine, you know. I had to make sure I didn't overdo it. I did, you know, I took a couple days off work, but then I just worked from home after that, and I know that I overdid it one day, just working way too late into the night. I had too much screen time, and I did give myself a hell of a headache, but a hell of a migraine. But you know, I recognized that and then made a point of just letting myself rest and recover, and really did feel.
And that took a few weeks, or
yeah, just
okay.
yeah, I think couple to 3 weeks. Like it really wasn't it wasn't bad, and you know, as the pictures show, it looked worse than it was. Like I did not feel terrible. I was able to, you know, take care of myself. Like my mom came up and stayed with me because my husband was fishing. And had a fishing trip scheduled before I booked the surgery. So
did you give him a pass on that one?
I did, absolutely,
okay,
of course, yes. And he was more. My mom was more there to just kind of take care of my dog, so that I have a puppy, and she
so you could
bash
recover
me in the face.
Yeah.
We wanted to not have that happen, but yeah.
So I understand this surgery did not completely cure your migraines. How much of a difference has it made?
You know, it has made a significant difference. Like I have to set my expectations appropriately, and you know, even conversations with Dr. McGee and my neurologist, Dr. Ford, it was like I didn't expect walking out of there, or once I was done, going, okay, I'm never going to have a migraine again. But I could feel the difference in the pressure in my head. I could feel the lack of pain. I was actually able to touch my temples and not immediately feel the pain of nerves that were inflamed. I was able to take one treatment pill, and that would be enough to actually kick a headache instead of having to take 2 or 3.
Yeah, that's amazing. That's what I wanted to ask. So you basically went from 3 pills down to 1 pill and less frequent. Is that right?
Exactly. Like I went all of last week without having to even think about having a headache.
Okay, let's knock on some wood or
I know.
something.
Oh, exactly. Yes.
Dr. McGee, is Sarah's case pretty typical of what you've seen in other patients?
You know, it's pretty familiar. You know, we certainly see a lot of patients who come back and have a significant decrease in frequency and in intensity of their headaches. They certainly, you know, we always would like to see patients who come back who are headache-free, and we do have, you know, a few of those patients. That's not the expectation. You know, what we expect to see is that we turn it down from being a, you know, 2 or 3 times a week occurrence to maybe being, you know, a once a week occurrence or less than that, hopefully. But also, if we can help them get off of some of their preventative meds, Sarah mentioned Topamax in particular, which can be very effective for a lot of patients as far as decreasing their headache frequency. It has pretty nasty side effects sometimes, and if we can decrease the side effect profile that these patients are having to experience, then that's also a big win.
That's incredible. If you have any questions for Sarah, Dr. McGee, or myself, send them using the links on your screen: YouTube, Facebook, the X platform, or email the Medical News Network. This is usually part of the show where Dr. Stites would normally check the COVID count, and we will get to that. I just want to keep Dr. Hawkinson on pins and needles. But nonetheless, since I'm flying this plane, let's check out the transplant count. This has been a busy year. So far this calendar year, the health system has performed 91 total transplants in just 3.5 months. That includes 14 heart transplants, 23 liver transplants, and 54 kidneys. That's just in this calendar year so far. April has been especially busy. We've done 24 transplants in just the first 16 days of the month. My partners have been extremely busy helping patients, so we thank them. I also want to take a second to acknowledge a couple things that are going on. The transplant nurses, it's Transplant Nurses Day. It is also Medical Lab Professionals Week and Neurodiagnostic Tech Week. We want to thank all of those people and for all the work they do in the weeks and months and before for every transplant and for every single patient as they usher them through a very difficult time in their lives. It's a team effort, and thank you very much. So now let's check in the COVID count with Dr. Dana Hawkinson, our Medical Director of Infection Prevention and Control here at the health system. So Dana, cold and flu season is finally over. Is that right, Doc Hawk?
Yeah, absolutely. I was going to say that respiratory viral season is really kind of officially ended April 1. Overall, the national rates of influenza are going down. So you're exactly right about that. So we do expect those other respiratory viruses, again, other than SARS-CoV-2, to significantly decrease in circulation. So you're actually absolutely right about that, Sean. And what I was going to say was that it doesn't matter because Stites pivots all the time, psychs me out when I'm coming on or not. So that is nothing unusual. And I'm glad we could show that in the amount of transplants and the amount of people that you and your teams are helping every year, and certainly going strong in 2024. I was also going to say that, so thankful to work with you guys, and so thankful that we have you in our community, and that is those surgeons. And those surgeons like you and like Dr. McGee, our guests, with just that exquisite skill to do that. But I was going to say, after watching that video, I would rather have you do a Whipple or a transplant on me in my abdomen, rather than seeing and looking and feeling that manipulation under my eyeball and eyelid and around my eyeball. That just kind of was a good wake-up call this morning. So a lot of skill needed there.
Hawk, I work with Dr. Hawkinson a lot. He takes care of, as an infectious disease specialist, he takes care of a lot of our transplant patients. And I very much appreciate that. But I always thought you, as an intelligent guy, you really would rather have a Whipple or a transplant than this procedure. I'm surprised.
I don't know. I don't get too grossed out, but just the thought of the stuff under my eyelid and around my eyeball just kind of was a little bit giving me goosebumps. So, but
well, thanks for acknowledging the surgeons. We all appreciate it. Thank you so much.
Yes. And to the COVID count itself, so just as you said before, and we talked about decreasing overall in respiratory viruses, COVID, hopefully we will hope is decreasing in circulation. We have 8 active patients in the hospital, so down to those single digits. And we'll just see if we can get down to 0. Obviously, we would like that, but we know SARS-CoV-2, we're going to be living with that for quite some time. And again, most people, the pandemic is over for them. But we have to remember those certain populations where it is a very real disease still and can cause significant morbidity and mortality, much like your transplant patients. Those immunosuppressed patients are certainly still at risk. So we have to be sensitive and understand that there are certain groups who are still at risk of severe disease as well.
Right, thanks. Another topic here I wanted to bring up, oftentimes physicians are approached by their patients and lay people for help with antibiotics. They feel sick and they feel like a pill might be the right thing to fix them. So doctors need to use antibiotics really wisely so that we don't have to create any drug-resistant superbugs. You saw a new study looking at what happened when antibiotics were used to treat coughs. What did that find?
Yeah, this was an interesting one, and I think we've all had friends, we all hear, and I certainly do, oh, I'm going to go to the doctor and get a Z-Pak because I've had a cough for 3 or 4 days, or whatever that might be. But this was a study at 3 major sites, Washington, D.C., Athens, Georgia, and Madison, Wisconsin, over the course of 4 years, looking at more than 700 patients. And they actually had PCR-confirmed infections with either bacterial or viral illnesses. And what they found was that those people that got antibiotics, it did not reduce the symptoms of cough as far as severity and duration. Those people that got antibiotics and that did not get antibiotics had the same duration of cough. So I think we have to understand that just because you have a cough does not mean you still have an infection. If you do have a cough, it doesn't really necessarily even mean that you have a bacterial infection that you need antibiotics for. I think that is important. And we both know that 80% or more of coughs, if they're related to infection in the community, are more viral diseases, which a Z-Pak in particular, but other antibiotics as well, will not work. So I think it's important to continue to understand we have to use good antibiotic stewardship and prescribing practices and really use antibiotics when they are needed. We absolutely want to do that. But we also have to, on the other side of that coin, we also want to be able to not use antibiotics when they are not indicated, because it can be a burden to the patient. Sometimes it's a financial burden. Sometimes it's a side effect burden. And then you also talked about increasing resistance rates as well in using antibiotics when they are not necessarily needed. But this study helps understand that, hey, even if you get antibiotics, you may still have that cough for some duration after you stop taking the antibiotics. And a lot of that is just your respiratory system and your lungs just kind of getting back to normal and gaining their function back after that illness.
Great. Thanks, Dr. Hawkinson. You know, judicious use of antibiotics, stewardship, and education of the public is extremely important. Thank you very much for all you do. We know many of you have questions. Let's head to Studio B with Alexis Del Cid. Alexis?
Good morning. We have a great question from Kim Bosley Moore. Kim wants to know, how long will the effects from this surgery last?
The expectation is that the long-term effect should be pretty stable. So this should stay how it is.
So that's indefinitely? That just one and done?
Well, one of the things we do see is sometimes we'll kind of take out a primary headache generator for a patient. We'll improve like the spot that was worst, and then we will frequently end up having to go back and address kind of secondary headache generating spots later on. That's pretty common with this, but it's not addressing the same spot as much as going after another spot that we need to improve upon.
Jeremy has a question. Jeremy Yenser has a question for Sarah. He wants to know, did you notice an improvement in your sleep after the procedure?
I have absolutely noticed an improvement in my sleep. My headaches tended to come on overnight, so I would be impacted around 3 or 4 a.m., and so that would wake me up. If I went to bed with a headache, that would also make it challenging to sleep. So yeah, I have found a significant improvement with that, and having less drugs in my body trying to fight off all the headaches also helps with sleep, because, you know, up or down, things seems inevitable that all migraine medicines make you tired, but then they don't help you sleep. So
Marie has a question. Marie wants to know, she would like an explanation on exactly how is Botox helping with migraines.
So there are a couple of theories about that. The first thing is the kind of more mechanical theory that I tend to think about more is that we're paralyzing the muscle that is irritating the nerve. And if that muscle isn't kind of torquing on that nerve anymore, then that nerve is not going to be irritated as much. There are also some pain improving properties that Botox seems to have that we are still trying to understand better.
Laura has a question, and this is again for Sarah. Laura shared that she gets horrible migraines, and she writes that sometimes I feel like people around me doubt how bad they are. Have you ever had this happen to you?
I have. I think most people in my life, thankfully, do struggle from severe headaches, so they're not completely unaware. But yes, people who have never had a migraine don't understand that it's not just a headache, that just taking a couple Tylenol aren't enough to fix it, and don't understand why you can't just shake it off, get up and go, and be on with your day. So you can either take the time to try and educate someone to really understand the difference, or just know your own truth and know how it is for you, and just don't worry about it.
Boy, that must be frustrating to not be validated when you're suffering so much from something that can be so debilitating. Jillian has a question. She wants to know if it's possible to target any other nerves for the same effect.
Yes. So we see a lot of people with occipital neuralgia, occipital pain kind of behind their head that radiates forward. They'll frequently come in and say their ear goes numb, and then when their ear goes numb, they know they're about to start having a headache. We'll see patients with other headaches that are kind of related to their temples in particular. So there's several different pain generating sites, and that's what we frequently see is we operate on one site, improve that site, and then we discover that there's another site that wasn't quite as bad but is now becoming the primary site. So that's when we're frequently going back and operating on patients for other things in the future.
Such a great discussion. I'm sure we're going to get more questions throughout the day, so we will be forwarding them to you or to Sarah as we get them.
All right. Thanks, Alexis. Really appreciate it. This has really been a great discussion. I'm grateful to our guests for being here, and I just wanted to get some final thoughts before we go. Sarah?
Yeah, I think anyone that has migraines has to recognize that it's a chronic symptom that isn't always viewed as such. And I think to find treatment to have a better quality of life, you just have to stay on it. You know, everyone always says be your own advocate, and to me that means being as persistent, pushy, not taking no as an answer as best you can. You know, you don't have to be rude. You want doctors to like you. But, you know, still stay on it. New things come out constantly, and it's a game. And as soon as you kind of learn how the insurance game and medical, just the processes game kind of works, then you'll know how to be a better player, and you can get a better outcome for yourself, and better quality of life. So.
Right. Thanks, Sarah. Thanks for being here.
Yeah.
Dr. McGee?
Yeah. You know, the biggest thing is that not every treatment works for every patient. Some patients do great with medical management of their migraine headaches, and if that's the case, surgery probably isn't something that's for them. If things like that aren't working and things like Botox and neurotoxins are improving things, then considering surgery is something that's worth at least looking at.
Great. Thanks for being here, Dr. McGee. I just want to say one of the great things about this program is that we get to educate the public about things that they don't always hear about. Even more so, we get to educate our colleagues about this. So we were talking before the program with Sarah and how she went through the process and got connected with certain other physicians along the way, and they knew about this. And they learned about this through programs like this. So I just want to thank Dr. Stites for having this program and allowing me to pinch hit for a little bit. So thanks again to all of our guests and to our audience. We've given Dr. Stites another week off next week, so I'm looking forward to being your host again next Wednesday on another edition of Open Mics with Dr. Coomer. I'll see you then.
A new mom goes from spending a morning snuggling with her baby to the emergency department and a stunning diagnosis. I'm Alexis Del Cid. On the next All Things Heart, the treatment and the changes she made to her life personally and professionally.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.